Good afternoon, everybody, and welcome and thank you very much for joining us today for the Meet the Expert webinar on febrile, allergic and hypotensive transfusion reactions, responsibilities, impact and best practice. We are delighted to have you with us. In this session, we'll have a presentation from our speakers, followed by an interactive Q&A session, and we'll finish with a quick feedback poll. Your microphone will be muted throughout the session, and although there is no chat function today, we really want to hear from you. So please pop any questions into the Q&A box at any time, and we'll endeavour to answer them during the presentation, and we have a dedicated Q&A session that follows this anyway. Live captioning is available during the webinar, and you can switch this off if you prefer. At the end of the session, you'll be invited to take part in a short feedback poll, and we really do value your thoughts and feedback as it informs our future educational sessions and webinars. You're also encouraged to encourage your learning from today, and you can claim 1 CPD point for attending this. Please note that this webinar is being recorded and will be available on the SHOT website in due course shortly after the session. It now gives me great pleasure to introduce our presenters for you today. Next slide. The panelists for this webinar are Dr. Catherine Booth, who's a consultant hematologist, NHS Blood and Transplant and Barts Health NHS Trust, Claire Rowe, who's the SHOT Clinical Incident Specialist, and Emma Milzer, who's the SHOT Hemovigilance and Patient Blood Management Specialist. The webinar will also be supported by various members of the SHOT team. The webinar overview includes the 2024 annual SHOT report data, including key findings, getting the management of the febrile, allergic and hypertensive reactions right, getting the investigation right, and strengthening FAHR reporting within your organization. Just a little bit of extra information. All cases used in this webinar are anonymized. They're all based on information provided to SHOT via the Dendrite reporting system. They're all representative of the data suppliers, and they are all used purely for educational purposes. It now gives me great pleasure to hand over to Emma Milzer, who will be our first speaker for today. Over to you, Emma.
Thanks, Karen. Okay, so you can move on to the next slide, please, Claire. So just a quick overview. This slide shows how FAHR reporting has changed over time and who reports are mainly about in 2024. So if you look at the first graph there on the left-hand side, you can see the number of FAHR reports each year from 2015 to 2024. And there are a few ups and downs, which you can see, but overall the trend is increasing. And we had the highest number of reports in 2024. However, this might reflect increased awareness and reporting rather than a sudden change in incidents. And the right-hand image breaks down by demographic. So here we can see that more reports involved females than males in 2024, and that the majority of reports were in adults. And there was a total of 354 reports received in 2024. Next slide, please, Claire. So this focuses on some of the gaps that were identified from the 2024 data. And one of the main issues is a lack of knowledge among clinicians when it comes to correctly classifying FAHR reactions and knowing which management and investigations are appropriate for each type of reaction. And another gap is on the laboratory side, where staff might not always feel empowered to challenge requests that aren't appropriate. And as a result, unnecessary investigations can still go ahead, even when they're unlikely to add value to the patient. However, these gaps highlight an opportunity to improve both clinical management and the use of laboratory resources, which is why we're here today, to share the learning and knowledge with you. Next slide, please, Claire. So let's firstly discuss getting the management right, and we're going to start with a case study. So this first case is an example of untargeted management following a febrile platelet reaction in a patient. So the patient developed fever, rigors and breathlessness and reduced oxygen saturations shortly after a platelet transfusion was administered. And they were treated with multiple medications, including steroids, antihistamines and pethidine, suggesting that the reaction wasn't clearly classified at the time. And although further investigations such as the chest x-ray were clear, plans were still made for future pre-medication for this patient. So the key learning points were that this represents a febrile reaction rather than an allergic one. And breathlessness in the absence of wheeze suggests a systemic inflammatory response rather than an allergic reaction, so obviously more in keeping with a febrile type reaction. And the reduction in oxygen saturations reflects severity of the reaction rather than primary lung pathology. And in this case, perhaps pethidine administration could have contributed further to respiratory compromise in the patient due to opioid-related respiratory depression. So the correct approach for this particular case was probably paracetamol and avoidance of steroids. So some general learning points. So the main learning points are that all areas where patients are transfused need to be able to recognise and manage transfusion reactions appropriately. And antihistamines and steroids don't have a role in febrile reaction. And management should always be guided by the patient's signs and symptoms to distinguish between febrile and allergic reactions, because these are managed very differently. Next slide, please, Claire. So looking at febrile reactions specifically in 2024, of the 179 cases where treatment was documented, about a third, which is about 35%, were managed inappropriately with antihistamines and or steroid treatment. Why does it matter? So it matters for a few reasons. Firstly, it can lead to patients receiving unnecessary or inappropriate treatments, while more appropriate treatment may have been missed. It also adds to staff workload through extra prescribing, monitoring and investigations, which is particularly significant in already stretched services. And finally, it can influence future care plans for patients. For example, patients being routinely given steroids when they might not actually need them. So what can help? There are a few things that can really help here. So making sure that transfusion practitioners and haematologists are really used as subject matter experts, that these are consulted to help with these types of reactions. Having quick visual reference guides readily available in clinical areas can also help support decision making when reactions occur. And careful clinical assessment of the patient can help differentiate the type of reaction and guide appropriate treatment. We acknowledge that when these reactions occur, it can be a really stressful situation, both for the patient and for staff involved. So there may be a tendency to kind of throw everything at that patient, whereas actually just taking a minute or two to clinically assess might help to prevent this blanket approach that we sometimes see that's given to our patients. And finally, embedding national and SHOT guidance into training and education ensures practice stays consistent and up to date. This guidance, which can be found in the annual FAHR chapters, clearly shows that treatment and prevention should be reaction specific. So paracetamol should be given for febrile reactions and targeted measures for allergic reactions, and avoid routine steroid use. So that's a good resource to be mindful of. And moving on to the SHOT transfusion safety standards. These emphasise patient safety, risk reduction and consistent best practice, all of which are directly relevant to recognising and management of transfusion reactions to manage those appropriately. And Standard 1.7 specifically highlights the need for prompt recognition and appropriate treatment and management of transfusion reactions, supported by targeted investigations, clear planning for future transfusions, and also robust documentation. So next I'm going to hand over to Kath, who's going to give us an overview of investigations.
Thank you very much, Emma. So, yeah, the next step is getting the investigation of FAHR reactions right. So again, let's start with a case from our files. So this was maybe suboptimal investigations for an allergic reaction to platelets. So this was a 6-month-old child who was transfusion dependent, so requiring regular platelet and red cell support. And they had a history of allergic reactions to platelets, and actually a plan had been made for an antihistamine before their platelet transfusions. But on this occasion, in spite of their antihistamine, shortly after completing their transfusion, they developed swelling around their eyes, vomiting, and there were systemic changes that might suggest cardio-respiratory kind of compromise, so increase in respiratory rate, increase in heart rate. And it was felt that this represented a severe allergic reaction, and the child was appropriately treated with adrenaline. So we have quite a low threshold for giving adrenaline in a severe allergic reaction in a child where it's hard for them to vocalize exactly how they're feeling. So I think management here, very appropriate. However, I think there was room for improvement in the way that the reaction was investigated. So the child was investigated with a repeat group and screen, a mast cell tryptase, and with blood cultures. What was optimal here? I would argue probably none of those investigations would have added to that child's management. So the national guidelines from the British Society of Haematology would suggest that any patient having a really significant acute reaction to transfusion should have a kind of a baseline set of routine tests sent, so a full blood count, renal, liver tests. And that's really just as a baseline in case that patient continues to deteriorate and you've got something to compare with. But in terms of the specific transfusion related investigations, let's look at those in a bit more detail. So first of all, repeat group and screen. So remember, a blood group and antibody screen is looking for antibodies to red cells. So essentially you're asking the question, has this patient had some sort of hemolytic reaction related to red cell antibodies if you're sending that test? So red cell antibodies or hemolytic reactions manifest as febrile type reactions, or maybe as a severe drop in blood pressure. And red cell antibodies cause reactions to red cells. So here the child had a reaction to platelets. There are very, very few platelets left in very, very few red cells left in a unit of platelets. So even if the child had red cell antibodies, they wouldn't cause a reaction to a platelet unit. Also, red cell antibodies do not cause allergic reactions. So allergic reactions are mediated by are against kind of non-specific proteins in that individual donor's plasma. So they're not related to red cell antibodies. So there's no role in repeat group and screen testing in allergic type reactions. So easy to remember, you only need to send repeat serology if the patient's had a febrile type reaction to red cells, or if appropriate, if you deemed appropriate on your clinical assessment, a kind of isolated hypotensive reaction to red cells, not platelets or FFP. So the next test that was sent here was a mast cell tryptase. So yes, this is a test that we can use in allergic reactions, but its value really comes in where there's some uncertainty about the diagnosis. So what mast cell tryptase can do is to support a kind of a diagnosis of anaphylaxis where you're not sure if that was what was happening. So if your patient has barn door anaphylaxis, if they're having a platelet transfusion and they come up in massive wheals and swelling around their eyes and they're wheezing and the blood pressure drops, that patient's had a severe allergic reaction, clinical diagnosis made. The kind of scenario we use this is particularly if patients under anaesthetic and the blood pressure drops or they become difficult to ventilate. And there's a million and one things that could have caused that under anaesthetic. So here, actually, mast cell tryptase can make a diagnosis and can retrospectively rule out quite a lot of other kind of pathologies. The other time I've used it is where you have a really severe, just isolated hypotensive reaction, where you think, well, that could have been bacterial infection, it could be anaphylaxis, it could be just a pure hypotensive reaction. And again here, tryptase could come in useful. So what you need to do if you are going to send a tryptase is send serial samples. So you should try and take one sample close to the onset of symptoms, obviously once the patient's been clinically stabilised. Then we try and catch the peak, which comes 1 to 2 hours after the onset of symptoms. So you need a second sample there. And then to get results that support a diagnosis of anaphylaxis, what we want to do is demonstrate a rise and then a fall back to baseline of this tryptase level. So you then need to take a baseline level, which needs to be 24 hours or beyond, to prove that you had a rise and then a fall. And then the classic curve is you get a peak of above 14 micrograms per litre and then a fall back to a lower baseline. Next slide. And then this child also had blood cultures taken. So blood cultures, you're looking for bacterial infection. So really, there's typically you'd only be sending these if the patient had a really severe febrile reaction or potentially a severe isolated hypotensive reaction during a transfusion. So bacterial contamination of a blood component doesn't cause allergic type symptoms. Now, obviously, we don't have very much clinical information about this child. There may have been other clinical features in that individual assessment that made them query a potential infection in this child. But in general, if you've got a really obvious acute allergic reaction, there's no role for blood cultures there. So how often do we get this right? There's room for improvement. So in terms of the serological testing, we saw from last year's SHOT report that there was unnecessarily repeat serology in 22% of all of the cases. And that included about 40% of reactions to platelets had red cell antibody tests repeated. The same sort of percentage of reactions to FFP and cryoprecipitate. Again, red cell antibodies irrelevant. And about the same proportion of purely allergic reactions also had repeat serology. So all of these could have been avoided. And similarly, we saw almost a quarter of allergic reactions investigated with blood cultures of the patient and sometimes also cultures of the unit. And we saw mast cell tryptase sent in some febrile reactions. So again, here there's lots of investigations that are not going to yield results that will help your patient. Next slide, please. So you might ask, oh, well, does this really matter? Surely more tests are the better. You might pick up something that's it just could be helpful. I'd argue we really do need to be targeting our investigations just as we should be targeting our management. So you are taking additional blood samples here, and here we had a 6-month-old child, and they're already transfusion dependent, so we don't want to be taking extra blood from them that they didn't need, and there's all the potential distress of repeat phlebotomy in any patient, but particularly in a child. There's also the time for a clinician to be requesting, taking, labelling, sending these samples, and potentially more than one set of samples if you're talking mast cell tryptase. Then you've got all the work for the laboratory, so the transfusion laboratory, but also biochemistry laboratory, the hematology laboratory, the microbiology laboratory, all for tests that are unlikely to yield anything. And when it comes to repeat serology, often this is quite manual testing, which can be quite involved for the laboratory. It might take a biomedical scientist away from other tasks for quite a period of time, and means that they're not available then to be issuing blood to the rest of your patients. And also for your individual patient you're looking after now, if the laboratory are working on a repeat sample, they're going to be reluctant to issue you more blood components until their workup is complete. So classic scenario, patient gets a bit of an allergic reaction to a unit of red cells, and you've sent repeat serological testing. And the patient, you stop the transfusion, so the patient still needs another unit of blood. The lab will say, well, no, we've now got a sample that's in progress, and you can't have any more blood until we've done what you asked us on this sample. So potentially you could be causing harm by creating delays for subsequent transfusions for your patient. Next slide, thanks. So what can help to do it better? So again, we really need our transfusion teams, so our hematologists and our transfusion practitioners, to be really confident in knowing which tests are indicated and when. And that's why you're here today. And so you're all going to tick that first box. Again, this is confusing for clinical teams. So we want to make it as easy as possible for them to do the right thing. So can we make really quick, visually easy to digest guides available, at the point of care on the ward. And then for our laboratories, how do we empower them to be able to question the appropriateness of a repeat serological test? So it can be very helpful to design your transfusion reaction reporting form to help provide that guidance to the laboratory teams and to your transfusion practitioners. So to kind of, I've got an example from my trust here where we've highlighted which are signs and symptoms that are allergic versus febrile, and put a reminder there that purely allergic reactions, we don't need to do serological tests, or reactions to platelets, plasma components, we don't need to repeat the serology. And that just provides an opportunity for the transfusion teams to be able to say, oh, is this, do we really need this? Is it really helpful? Next slide, thanks. So that brings us nicely to how we feed back to our clinical teams if they maybe haven't managed or investigated a reaction in the most appropriate fashion. And we really want to be able to do that so that our clinical teams can learn. But those kind of conversations can feel quite difficult to have. So you don't want to be coming across as critical or accusatory. And exactly as Emma said, that it is a stressful time if someone's managing a patient with an acute transfusion reaction. But it doesn't mean we shouldn't do it. So it's really about how we frame those conversations as a really good learning opportunity, not as a criticism, not accusatory. So the way I would start is if you've identified a clinician you're talking to, start by with positive feedback. So, thank you. Saw you assess that patient who had an acute transfusion reaction, and it was great. You came really quickly. You clearly reassured the patient. You clearly reassured the nurse. You've given a clear plan about stopping the transfusion. I was reviewing the kind of the symptoms there, and it looks like it was a febrile type reaction, and I can see they were given hydrocortisone and antihistamine, and actually those are really good for allergic symptoms, but paracetamol might have made the patient feel that had the best effect on making the patient feel better. And then you can offer a resource, so something to help that clinician. So, I've got this great SHOT bite that summarizes the treatment to give really clearly. I'll send it through to you and share it with your colleagues. And there it really then becomes very much a learning opportunity. I know I'm not seeing anything there that's, you did it wrong, you gave the patient the wrong thing, or you could have given them side effects. No, it's all about this treatment might have been the really best for this patient. And so I think that the language we use there is really key to framing those conversations, right? So think about moving away from anything that's suggesting blame or challenge, or this is an incident, or so you failed to do something, and really move over to something that emphasizes that this is about learning, about best practice, about following recommendations, and then I think you'll find that you've developed a really good partnership, and you've got trust with the clinician you're talking to, and that's always beneficial because then they're more likely to come to you in future when they need transfusion advice, which is exactly what we want. Okay, so I'll pass on to Claire now to talk you through kind of the best practice for reporting these reactions.
Thanks, Kath. So I'm just going to have take you through reporting tools at SHOT and talk about how that happens, completing the report, some common follow-up questions, analyze and look at the reports that we withdraw and kind of understanding why, and then some case study examples and some resources. So I'm sure all of you that do report to us are aware, and for those of you not, know that we do it via a platform called Sabre, and these are the categories of which we would like you to think about with submitting report under FAHR. And I think really it's about thinking about picking those up in clinical practice, and obviously if you're a TP, this is probably part of your role day to day, but if that's not, it's understanding an opportunity to understand what here at SHOT we want to report to us, and understanding the definitions of those, and they can all be found in the definitions document which is on our website, but these are the main categories, and that's how you would do it. And then they go onto the Sabre platform, and then they come through to us. Once they come through to us at SHOT, we will take in those reports and start to analyse them, and we'll move through those and have a look at the reports that have come through. And very often we will need some additional information, and again, recognising how busy everybody is that's completing these and the pressures that everybody is under, I thought it would be useful to go through some of the common questions and that additional information that we often have to request for, and to highlight those, so that when you're completing the report, you can understand that if you can complete it in its entirety initially, that's fantastic. Recognise that's not always possible, but how important that data is and the benefits that it might have. So quite often, and you'll need to come back to you to ask if you've acknowledged that the patient had a temperature to get that pre or that peak transfusion temperature. Often one or the other might be missing, and we really need that data to be able to make an analysis of particularly what category that may fit in. We often need to know the blood pressure, particularly if you are talking about a patient being hypotensive, to make sure that we can acknowledge that it fits in within that definition. So really key to add that pre and that peak blood pressure, particularly during that episode of reaction. So any details of any medication that the patients had during that reaction, and particularly the sequencing and timing of that reaction. So did they have it just before the transfusion started, during the transfusion, what came first, the dosing, that's really important as well. So again, as much information and as much details as you can give is really important, but because this is quite often the information that we all come back for. And the serology, so was the test sent and what was the findings? You might not be able to have that information initially right at that point of doing that report. Absolutely feel free to send that information on to us later on when you do have that. That's absolutely fine. Recognise that this information is not always available to you. What's really important as well is to understand the symptoms that are related to the patient's underlying condition. So the more details that you can give about that is the better. And I recognise in a lot of these situations, this is information which you are gathering sort of second hand, in the fact that you weren't there during the reaction, and that you're trying to gather this information. So we understand how difficult it is, but these are often what we come back to. What would also be really important is if that information is just not available. So if there is no pre-temperature, or if there is no pre-blood pressure that was taken beforehand, then if you can acknowledge that, put that down onto the report, that's really helpful. It just saves that email back to you to ask if you have that information, if it's just not available, or if there is information that isn't available but may well be, again, put that into the report. The more information you can give, the better. Had a look at last year's 2024's report, and about 28% of the reports that were submitted we did end up withdrawing, and as you can see, this is the reason why. So the huge majority of the cases that we withdrew are down to the patient's underlying cause that wasn't related to transfusion. Again, we absolutely recognise that it's not always clear cut, and it's not always immediately obvious where that reaction or that underlying cause may sit. We would never discourage you from not submitting that report, but it's just, again, if you've got any information regarding that, if it's a conversation that you've had within the team or an external team to say, actually, on reflection and after analysis, we've decided that this initial reaction was related to the underlying cause or patient's condition, always feel free to email that in at a later date or add that to the report. All this information is really important. And then the other thing that we find a lot, as you can see there, is the mild reactions. So SHOT doesn't take the mild reactions when it comes to FAHR. So if there is anything like in there, feel free you don't need to submit that. Filling the reports in, again, we recognise takes a lot of time, so use the definitions to make sure it fits. We'll talk about this later, but if you're not clear or you're not sure, then you're always very welcome to contact us. Insufficient information is also, we often just can't make a decision on where that category can fit because we just don't have that information. It may well be that either it's not available initially, or that follow-up email, we still don't have that information. This was a little bit more deeper of the analysis. So as you can see, lots of patients with the infections and sepsis, and that might be the underlying cause. Again, that mild reaction not meeting that SHOT criteria. The hypertension, again, if you can give us as much details as possible, that really helps us meet that definition. And then you can see here an insufficient information, so too little data to assess, the observations aren't available, the documentation is incomplete, lack of transfusion timing in the linkage, so we can't make a conclusive decision, missing investigation results, and the reporter unable to provide further information. And then sometimes they do get duplicate information, and that's absolutely fine. And why does this matter? Well, it's really important. Ultimately, the patient is at the heart of our data, and we really want to gather the best and most detailed information and data that we can, so we can improve the outcome of that data to improve our practice, and then ultimately works to supporting our patient. But it's also recognising how busy everybody is that's completing that report, and that we don't want to be going back and forth for you and for us. It's all that additional information, and also without that detailed information, it's a challenge sometimes for our working expert group to make those decisions, because obviously we weren't there at the time. And then again, like I said, any information that we can make sure that we can be consistent with the definitions, and that produces good high quality data. An example of that might be that this one case was withdrawn because this was a patient who had iron deficient anemia. They had a pre-transfusion temperature of 36.8 degrees. They had 1 unit of red blood cells, and then they rechecked the temperature at the peak of the reaction, and we can see that doesn't meet the moderate temperature, just the mild there. So that would be not SHOT reportable, and then so we would have withdrawn that. So you don't need to report that to us. And this is another case study where the patient's underlying condition, so it's a patient with influenza and pancytopenia, patient receiving red blood cells, they became tachycardic, temperature dropped, but the ECG showed fast atrial fibrillation, which is irregular fast heart rate. And then we can see there, treated with 500 ml bolus of fluid and IV digoxin. And from that really good quality data and that good quality information, we're able to withdraw that due to the decision that this was actually the underlying patient's condition. We'd really like to help you make those decisions and any resources. So you're always very, very welcome to email or ring any of us here at SHOT, and we'll help with that decision making. And if we can help decisions, we're very open to doing that. The new SHOT definition document will be coming out very shortly, and one of the changes that we've made is that we've brought the definitions much closer together now. So your FAHR definitions and then the classifications are now next to each other rather than being several pages apart. So hopefully that should make it, from a usability point of view, a little bit easier. And then the other thing that's coming hopefully in the spring is a reporting assist tool. So this will be a tool to be able to, not a diagnosis tool, but a tool to help you make a decision on whether reporting you should report to us or what category it might fit in. And that's something that should come through hopefully in the spring, and that again to support you make that decision. Now, here at SHOT, we have a huge amount of resources and really want to make sure that you're aware of them to support your practice. So lots of information and lots of QR codes here, but we've got the cumulative SHOT data, a really informative web page on our website. So lots and lots of data specifically about FAHR. We've got a separate area where our videos and our webinars live. So please go on there and have a look, use those resources. And then we have 2 separate SHOT bites, which cover a lot of what we've talked about today. So the management and then the testing and follow-up of our FAHR cases. So all there for you to be able to use. So please go along and have a look at those. We welcome any feedback on that. So if there's something that's not there or you feel there's something missing, please do get in contact with us and let us know. And then there's some additional resources. So we've got the blood assist tool, which is guidance on how to manage transfusion reactions. It's a generic app that can help you, that hopefully would help you within clinical practice. The blood components, app here, which is based on the MBCT indication codes. That's for adults, children's, and neonates. And then My Transfusion app, which is the SHOT app, which is predominantly based for adults, patients, carers, but also hopefully healthcare workers can use it. But it's there to help patients and carers through their transfusion journey, and it's in an accessible form via an app and via the web access. So hopefully that's useful, and if you are patient focused, you can pass that over to them to be able to use. Again, we welcome any feedback on that. Although it's for adults, we do also know that our paediatric colleagues have been using it for parents and carers to kind of give them some idea of what will happen when they have a transfusion. So that's it from us. We thank you for listening, and we open the floor to any questions.
Thank you so much, Claire. I think Vicky and I have got some questions in the chat. I think Vicky's going to go first.
Yes, fab. Thank you very much. So I'll just go from the bottom and work my way up, if that's okay with everybody. So the first question we've got is laboratory focus. So it said, in the laboratory, we often get requests for unnecessary tests following a transfusion reaction. How can I challenge a clinical request or test and communicate it effectively?
Yeah, and I think I can completely appreciate the challenge that laboratory teams often feel, and that's where practicing that the kind of language you're going to use, I think, is really helpful. And I really encourage you to download a copy of that SHOT FAHR on investigations, because you can always send that then to your clinicians and say, oh, okay, so we've got a sample for a repeat group and screen save here, a repeat group and screen test here. The time that's going to be helpful is if the patient had a febrile reaction to red cells. I'll send you a little guide. Do you want to check and then come back to me if I need to process this? Otherwise, you can get on and then you can always. I'd also, if you're feeling empowered and you've managed to have that conversation yourself as a biomedical scientist, make sure you've also signposted them to a source of clinical advice. So how to let them know, how do they get in touch with the transfusion practitioner or the haematology reg, who obviously are now super experts because they've been to this webinar. And so you've always got that clinical backup. I think that's really important for laboratory teams.
Fantastic, thank you. So the next question in the chat is, why do hospitals often adopt a blanket approach relating to treatment? Is this due to challenges in distinguishing between the different conditions, or do you think it's related to gaps in knowledge and understanding?
I wonder if so Claire comes from a nursing background. I wonder if you'd share you could share any of your insights from having been at the bedside, and then I'll share mine as a haematologist.
Yeah, I absolutely recognise it, particularly when you're in a busy situation that you have lots of things are happening all at once, and particularly when maybe haematology or particularly transfusion isn't your main focus if you're working in a ward area. So I absolutely recognise that challenge. I think we absolutely had this before, and one of the things we did was that we found our processes of how to treat this was actually well deep into an SOP, which was on either on a computer somewhere that was not by my bed space. So one of the things that we did is kind of brought that out of the SOP, and so had that accessible. And then one of the other things that we did is we brought blood transfusion into our sim training. So I think it's like anything, that if it's not something that you're doing regularly, and it's not something that you are an expert on, it's a challenge for you to be able to remember. And I think one of the things we did, is bring that within our sim training, and we also made sure that our senior staff were aware of this, because then you've got someone to refer to, particularly if you're a junior member of the team, and you're every day is a challenge, isn't it? So I think we made sure that our in my area, our senior staff were trained on this. It was part of our sim training, and we brought out that really important part of this massive, huge SOP, and brought out that relevant parts to us, and recognise those particular areas. And making individuals champions in your area, I think, is really important. We absolutely can't all know everything, but if you've got a couple of individuals on each shift that were aware of those particular specialties, then that really helps to bring out that particular knowledge.
Thanks, Claire. I'll chip in as well from my clinical experience as well, if you like. I completely agree with Claire. What we did, we had a unique sort of transfusion record, which was an all-in-one document. So everything went on that, including traceability stickers. And on the back, we had guidance for transfusion reactions. So everybody knew where that was, if that should occur. And the other thing the laboratory did was on the traceability tag, obviously we had one side, which was the patient's details and everything. And on the reverse side, we had a quick sort of guide to experiencing a transfusion reaction and what to do. So that would only be very brief, but it contained the most important things, you know, like to stop the transfusion, just hold on a minute and assess the patient, etc. Because I think, you know, hopefully most nurses or doctors, depending where you work, obviously, you may never see a transfusion reaction. And if you do, you know, you're not going to suddenly know what to do because it's such a rare occurrence, really. So it's important to have that information at hand. And also, you've got your different groups of patients, haven't you? So if you've got, say, a conscious patient and they're experiencing a reaction, even if it's febrile, it can be really distressing for that patient. You know, the rigors can look very frightening, they can feel terrible. So I think there's a tendency of staff perhaps trying to help the patient in that scenario, but, you know, just jumping in. But then on the other side, if you've got patients who are perhaps vulnerable because they can't communicate, like children and ICU patients who are sedated and ventilated, then they can't, you know, communicate how they're feeling. So you've got to make a judgment on their observations and things. So it's quite challenging at times, I think. You can see why these things do happen.
Have you got anything else to add to that, Kath, before we move you on?
I think they're really great insights, and I think just also illustrates just from two speakers there how many, you know, potential, often quite simple solutions can really really help. So I'm sure people on the call have a 1,001 other examples, but yeah, do have a think. You know, it's great for creative minds to see how we can best support all of our clinical teams.
Thank you. No, they all sound like really good ideas, lots of stuff happening. So this next one's a bit more of an admin kind of question for you, Kath, but somebody's curious about the transfusion reactions reporting form. Where can they find a copy of it? Could you share it? Because they're doing some work locally.
I'm very happy to share it. Maybe if you email the SHOT team and they'll forward you, I can forward it to them and they can send it out for you.
Thank you very much. Do you want me to carry on, Nikki? Because that's just more of an admin kind of one. Lovely. The next more knowledge-based question is about patient groups. So, which patient groups are at increased risk of recurrent reactions? Get your mouth around that one. Thank you.
So we do see, so relative to adults, children are more susceptible to transfusion reactions, and particularly to allergic type reactions. So we do see a subset of children who will have recurrent reactions to blood components. That's most people who have one reaction will have one reaction, and it's just if it's an allergy, it's just bad luck. That individual donor disagreed with them. If it's a febrile reaction, we don't know for sure what causes a sort of a simple non-febrile, non-hemolytic febrile transfusion reactions. It's probably sort of some cytokines in that unit. So again, it's just sort of bad luck based on the that individual bag. But there's certainly individual patient factors. So if you're an allergic type patient, so often if you walk up to a patient and you get their drug chart and the allergy list, you know, it's filled the box and gone on to the second page, and they've got lots of food allergies and medication allergies, you know, they're more likely to have an allergic reaction to a plasma component in that donor's plasma. And there's certainly individual patient factors. So if, you know, inflammatory reactions require the patient's immune system to be active to raise a response. So someone whose immune system is already active, so, you know, they're sick with something else, are potentially more likely to have a febrile type reaction. So I think, you know, don't assume someone will have a recurrent reaction next time round, but if you can pick up those factors, you know, the underlying susceptibility to allergy or to inflammation, then perhaps you might suspect there might be more risk next time. And I think that's the links with the fact don't necessarily rush in with pre-medications before a second transfusion if someone's had one reaction. We don't want to cause someone side effects from medications unnecessarily. And kind of once you've written pre-medication on a patient's chart, they end up committed to it forever. So unless they've had a life-threatening reaction first time round, in which case you're making a detailed transfusion plan for them, let them have a second transfusion with just close monitoring before you commit them to lots of drugs every time.
Super, thank you. So a more practical question. When is it appropriate to continue a transfusion after a fever has been assessed?
Do you want me to go with that again?
Yeah, you can do.
So this, I would signpost you to the British Society for Haematology guidance. We've tried to create a nice kind of traffic light system there to help you identify which reactions where you definitely need to stop a transfusion. But clearly a life-threatening reaction, which means impairment of airway, breathing, circulation, you're going to have to abandon that transfusion and work up the patient and stabilize them appropriately. Every other type of reaction, so mild reactions, moderate reactions, you're going to pause and you're going to assess. And the first step is really taking into account that patient's underlying conditions and why were they having the transfusion in the first place. So classically, you've got a patient who's been spiking fevers. There's, hematology patient. They're sick with neutropenic fevers. They're having a transfusion. They spike a fever. It's probably just their underlying neutropenic fevers, and we don't want to deny them the transfusion that they need. So, has the patient's clinical condition changed? Are they looking very different? We pause the transfusion. We give some symptomatic treatment potentially. So if there's fevers, we give them paracetamol. If they're clinically stable, they don't look any worse than they looked before, then it's probably very appropriate to restart. And then if things change, if they have another worse temperature spike or the new symptoms, then you stop it. So there's more time than you think, and shouldn't feel a pressure to make the decision straight away whether or not to continue. You've got likely an hour to play with to be able to make that assessment and see how they settle.
Kathy, if I could just, sorry, I was just going to say, I think this is when it's really important to make sure that you've got really good observations post the event and you're keeping a really close eye on the patient. And I think that's really important to make sure you've implemented those within the clinical practice, that patient is escalated and that gets the appropriate treatment, and reach out for those within your trust that may be able to help you to make those decisions so you're not making them in isolation.
Advice.
Absolutely. Thank you very much for all that. I'm going to skip forward a couple of someone who's been brave enough to identify themselves in the question. So we've got a question from PNT here from Lanarkshire saying that platelets understandably feature heavily in the FAHR talk. Thinking about purely hypertensive reactions, does the reporting data show any pattern as to which blood components these are most common with?
I think I would say, first of all, pure hypotensive reactions are very rare. We tend to get in the realm of 10 a year. And obviously that's in the context of 2 million components transfused across the UK. With such small numbers, it's difficult with generalizations. The data I've just been looking at for the report we'll be releasing, it was more red cell related. We get a bit of fluctuation year by year, but it's probably more the kind of cellular type of components, red cells or platelets, but with the caveat very small numbers. And again, we don't know completely what causes these pure hypotensive reactions. There's been various kind of theories, and there seem to be some patients who might be at slightly higher risk. There's been some link with the ACE inhibitors, so things like ramipril. The theory it's related to kind of bradykinins and things, but because they're such rare events, it's very hard to prove.
Thank you. There's a question here about when should we look for severe IgA deficiency and antibodies in patients having such reactions?
Excellent question. I could talk to you about this for another hour, but I'm sure you've got all got other things to go back to. So the kind of traditional perceived wisdom is that there's an association between severe IgA deficiency. So by this we mean undetectable IgA. So this is not patients with low immunoglobulin levels in the context of their chemotherapy or their myeloma treatment. This is patients with congenital who don't make any IgA, so undetectable levels, and sometimes in association with antibodies against IgA. And the traditional perceived wisdom has been that those can be associated with anaphylactic type reactions, so very severe allergic reactions. Now, again, these are really rare. So the SHOT we get reported a handful a year, maybe 5 or so on average. Whereas actually severe IgA deficiency is not that uncommon. So first of all, there's a little bit of controversy about the association with transfusion reactions at all. And when we looked back across SHOT data over a 10-year period, actually what we saw is not a great association with allergic type reactions, but much more a kind of inflammatory type reaction. So the kind of classic picture that I often see is something that presents more like as if the patient had had an ABO incompatible transfusion. So the patient gets a real feeling of doom, anxiety. They often get marked kind of systemic changes, so really increase in heart rate, sometimes a fever, loin pain, muscle pain, very distressed, considerable anxiety, and often with a temperature, and often very, very quickly at the start of transfusion, so within the first sort of 15 minutes. And interestingly, you'll often find that that they've had a transfusion sometime before, and that happened before. So what we wrote into the British Society of Hematology guidelines is if your patients have had recurrent kind of severe inflammatory type reactions to blood components, or it's still not unreasonable if they've had an anaphylactic type reaction, then it's reasonable to send IgA levels. And remember, it's only if it comes back completely undetectable that you're going to look into that anymore.
Thank you, Kath.
Lovely. Thank you very much. We've got a question here from Sharon, who's asking, we currently emphasise not to give treatment through the same IV line as paused red cells when you're treating a mild reaction. Does this guidance, is this the same? Does this guidance still stand, I think?
Shall I let one of my nursing colleagues answer that one?
Yeah, I think I was looking to Emma to see if I'd understood the question. So you are giving currently some red cells, and then you are treating that mild reaction, and I guess that line is now paused. I think I wouldn't reuse that line for anything else while you're treating that patient. Yes, because you absolutely then don't know the implications of what's happened. So if you're treating one thing, then you want to try and reduce as much activity at that point to make sure that you're managing that one particular symptom at that point, so you can recognize the treatment and understand what you're giving. I don't know if you've then made a decision to take that line down, you can flush it in the normal way and then continue to use it. But I think you would definitely need to think about hospital policy as well, obviously managing that line. If I've understood that question right, if I haven't, please add something else into the bottom of the question. I'm very happy to answer that afterwards. Emma, I don't know if you've got anything else to say.
Yeah, I mean, I guess because it says in the question we're looking at treating a mild reaction, got to be mindful of that as well. You know, what would we actually want to be giving intravenously, perhaps IV paracetamol if the patient can't take them orally, or, you know, is there an alternative sort of PR or anything like that? But that would be the main one. What we advise is if the patient starts to experience any kind of reaction, you know, even before you know what it is, we certainly don't recommend removing, you know, the cannula straight away, because that might be your only intravenous access. So we would always say just keep that in and keep it patent and everything. But if the unit does need to be returned to the lab, you would send the unit and the whole of the giving set, but you can leave the Venflon where it is. In reality, and I'm not advocating this, you know, that I think there's always going to be the very rare occasion where a patient only has one method of venous access, and if they should go on to experience a severe reaction, then I know some anaesthetists have had no option but to use that same line because they've got no other way of getting the urgent IV drugs that need to go into the patient. But in this instance, we're talking about a mild reaction, so hopefully, you know, that wouldn't be necessary. If the patient absolutely can't get any other IV access, then I'd be discussing it with the medical team really, rather than making that decision myself as a nurse. So yeah, hope that helps.
I would like that just to re-emphasize what Emma said there, is that so now you're targeting your treatment correctly. There's probably much less you need to give IV. So you're not going to be giving hydrocortisone. You shouldn't be using a steroid routinely in any scenario. And actually most reactions, so we see more febrile than allergic reactions. So you're going to be managing them with paracetamol, which can be given very nicely orally, or a nice dispersible one works quickly if you've got it. And even, you know, a mild allergic reaction with a rash, have you got an oral antihistamine? Why does that patient need a massive slug of IV chlorphenamine, which is going to make them drowsy and give them lots of other side effects? We're just trying to relieve their nasty rash. So, you know, an oral antihistamine, if they can take it, will work very nicely indeed. So, you know, if you're rushing to find the IV drugs, think actually, can I give something that's targeted and simple, that's oral, much less work for the nurses, quick for the patient, then you're not stressed about the line either.
Thank you, everyone. We have now run out of time for questions, but if you have any burning query that were not answered in this session, please email them to SHOT and we'll forward them. I would like to take this opportunity to thank all the speakers for this fantastic talk and for all the engaging questions that you was put on the Q&A. I hope you have found this session as interesting and useful as I have. Also, to let you know, this year is the 30th anniversary of SHOT, and the registration for this year's symposium, which will take place in Birmingham, is now open as the abstract submission. All information, you can find it on the SHOT website, and you can access the page by scanning the QR code that is on the right side. Next, we are going to launch a short poll for all attendees with a couple of questions. Please answer these questions, as your feedback really helps us improve the webinars. While the poll comes up to your screen, I would like to remind you that today's webinar has been recorded, as mentioned at the beginning, and it will be available very soon on the SHOT website. For this session, there will be no certificate available, but you can use your reflective practice document or something equivalent that you have in your organization to record this webinar as a CPD activity. Again, if you have any questions that were not answered today, please email us to the SHOT inbox, and our email address, for those who don't know, is shot@nhspt.nhs.uk. So just leaving the poll up for a little bit longer. Just to remind you, when you get to the last question, please click submit, otherwise we don't receive the answers. Just a couple of seconds. The poll is going to be closed very soon, and I would like to thank you all for joining us today. It has been fantastic, and I hope you have found this session very useful. We'll now close the webinar, and I hope to see you next time. Thank you so much for your attendance. Thank you.